He runs 3.1 miles, which is 5 kilometers 3 times a week. No huffing and puffing, no chest pain, no unusual fatigue. 6 weeks later, he is on the operating table for emergency heart surgery, with 3 arteries blocked by more than 70%. This is not a rare story. This is the mechanism. And that mechanism is working right now in millions of people who exercise, eat healthy, and believe their body will warn them before something happens. Your body does not warn you, not because it does not know, but because it is too good at adapting, to the point that it hides a 70% blockage behind a compensatory system that you feel as normal health. The question is not whether you have symptoms. The question is, what is your body compensating for, and how long has it been compensating? Over the next 11 minutes, we will decode that hiding mechanism, why it exists, why exercise is not proof you are okay, and why the heart test your doctor is using is designed to miss exactly this. Let us decode this together. Imagine your arterial system as a highway network. When a lane begins to narrow, slowly, over many years, the body does not sit around waiting for a traffic jam. It hires a contractor to build a bypass, quietly, in parallel, without announcement. That contractor has a name. That process has a mechanism. And most of the time, it works so perfectly that you do not feel anything unusual at all. There are 3 characters in this story. The first character is plaque, which slowly narrows the highway over decades, often starting when you are still in your 30s without any signs. The second character is positive remodeling, the bypass contractor. The only reason you have no symptoms even though the blockage is already significant. And the third character, this is the character most people have never heard of, is vulnerable plaque. Not the biggest blockage, but the real danger. The problem is not the 70% blockage. The problem is something that the standard cardiac stress test, the test where your doctor has you run on a treadmill, is designed completely to miss. We will get there. But this is where biology gets uncomfortable. When plaque begins to build up inside the artery wall, the body's first response is not to narrow the vessel lumen. It is to expand the entire artery outward to make up for the area occupied by the plaque. This process is called positive remodeling, and it works incredibly well to the point that an artery can contain plaque occupying 40% of the vessel wall volume, while the lumen looks completely normal on a standard ultrasound. A study from the Cleveland Clinic followed patients with significant plaque. More than 50% of them had no symptoms at all, not a single symptom, until they did. Your highway is not narrowing, it is being expanded around the obstacle. Traffic flow still runs normally. You run 3.1 miles, which is about 5 kilometers. Your heart still gets enough blood, and you do not notice anything unusual. The contractor is doing a good job. But the contractor has limits, and when that limit is exceeded, the second hiding mechanism appears, and this is something much more dangerous. Most people think that the bigger the plaque, the higher the danger. That logic sounds right, but it is wrong. What causes most heart attacks is not 70%, 80%, or 90% blockages. It is a 40% blockage, which is smaller, softer, and has a thin outer shell like a cracked egg. Stable plaque, the large, hard, calcified kind, usually does not rupture. It narrows the lumen slowly. Chest pain during exertion is the typical symptom. The body can warn you. Vulnerable plaque does not narrow the vessel significantly. It causes no symptoms. But when that thin shell ruptures due to a bout of stress, a sudden spike in blood pressure, or a well-timed inflammatory molecule, a blood clot forms in seconds, and a complete blockage happens in minutes. This is the signal that most people miss. The man who runs 3.1 miles, or approximately 5 kilometers, without symptoms does not have a large plaque squeezing his artery. He has small, soft, inflamed plaque, and no test in a standard physical exam looks for them. Now this is where it gets personal, because the heart test you are trusting is designed for the wrong type of plaque. The cardiac stress test, an electrocardiogram while running on a treadmill, measures one thing: whether your heart gets enough blood during strenuous activity. If there is a blockage large enough to restrict blood flow when you exert yourself, the test will detect it. The threshold for this test to signal an abnormality is around 70% blockage. Below that, even 60%, even soft, inflamed vulnerable plaque, the test gives a normal result. A meta-analysis from the Journal of the American College of Cardiology, looking at more than 100,000 patients, showed that the standard stress test misses more than 60% of clinically significant coronary artery disease cases. You run on the machine. Your heart works well. The doctor says you are fine, and neither of you is lying, within the scope of what that test is designed to measure. The problem is that scope does not include what is actually killing people. A calcium-scoring CT scan, which is a computed tomography scan that measures the amount of calcium in the artery wall, detects both stable plaque and indirect signs of vulnerable plaque. The cost is around $100 to $200. It does not require a doctor's order in many states, and most doctors do not proactively recommend it because it is not part of the standard routine screening protocol. So now that you understand why your body can hide this, here is how you look behind that curtain. The goal is not to worry about your heart. The goal is to measure the right thing before the contractor runs out of compensation capacity. Step 1. Measure with the right tool. If you are over 40 years old and have never had a calcium-scoring CT scan, this is the only test that gives you a real number about the plaque situation in your arteries. A score of 0 means no calcified plaque, indicating low risk over the next 5 years. A score above 100 requires a different conversation with a cardiologist, not with your family doctor. With a cardiologist. Step 2. Measure the right biomarker. High-sensitivity C-reactive protein measures systemic arterial inflammation, the trigger that causes vulnerable plaque to rupture. Below 1.0 milligrams per liter is ideal. Lipoprotein A, also known as LPA, is a genetic marker for vulnerable plaque risk that most standard lab panels do not include. These two numbers combined with the calcium score give you the picture that a stress test never will. Step 3. Reduce inflammation at the source. High-dose omega-3, an EPA and DHA combination of at least 0.07 ounces, which is equal to 2 grams per day, has been proven in the REDUCE-IT trial to reduce major cardiovascular events by 25% in patients with high triglycerides. The mechanism is reducing artery wall inflammation, thickening and stabilizing the shell of vulnerable plaque, not by removing the plaque, by making it less likely to rupture. Now you have the translation. Comment decode below if you have ever had a calcium-scoring CT scan, and let me know what your score is. If you have not done it, comment your age. I will tell you what threshold applies to you. The bypass contractor in your system is working day and night, but there is a fuel source that it consumes to operate, and most people are running out of that source without knowing it. It is what controls your vascular endothelium, and it is a mineral that 68% of Americans are deficient in. That is the next decode.